Good morning, ladies and gentlemen. I am Dr. Armen, Professor Armen Astvatsatryan from Yerevan, Armenia, and today we will talk about heart failure. So I remind you that you see Healthcare and Education. Healthcare and Education channel. This is channel for students of medical universities. And I am Armen, Professor Armen Astvatsatryan, once again from Yerevan, Armen Astvatsatryan from Yerevan, Armenia. And just for you, Professor Armen, like Armenia. So we start a chain of lectures concerning heart failure. So heart failure, what is heart failure? Heart failure is a syndrome of ventricle dysfunction. Left ventricle failure causes shortness of breath and fatigue, and right ventricular failure causes peripheral and abdominal fluid accumulation. So the ventricles can be involved together or separately. Diagnosis is initially clinical, supported by visualization techniques, echocardiography, chest X-ray, and levels of plasma natriuretic peptide. So natriuretic peptides. Treatment includes patient education, first of all, just changing of way of life. So diuretics, angiotensin converting enzyme inhibitors, AC inhibitors, angiotensin 2 receptor blockers, so Zartans, beta blockers, aldosterone antagonists, neprilysin inhibitors, sinus node inhibitors, specialized implantable pacemakers, defibrillators, and other devices, and correction of the cause of the heart failure syndrome. So heart failure affects about, just in the United States, 6.5 million people in the United States. More than 960,000 new cases occur each year. And worldwide, about 26 million people are affected worldwide. Okay, and I suppose this lecture will be mostly based on physiology because the first part of the lecture will be physiology. So, physiology of heart failure. Cardiac contractility, force and velocity of contraction, force and velocity of contraction, ventricular performance, and myocardial oxygen requirements are determined. Preload, afterload, substrate availability, oxygen, fatty acids, glucose, heart rate and rhythm, amount of viable myocardium. Okay? So cardiac output, when we talk about cardiac output, we have to understand this very important notion. Cardiac output is the product of stroke volume and heart rate. Okay? Stroke volume multiplied by heart rate. It's also affected by venous return, peripheral vascular tone, and, of course, neurohumoral factors. Quite important. So cardiac output, CO, is the product of stroke volume and heart rate. We will talk about this concerning Frank-Starling principle or Frank-Starling rule, and don't forget it, please. Okay? Cardiac output is a product of stroke volume and heart rate. Okay, so what is preload? Preload is the loading condition of the heart at the end of its relaxation and filling phase, diastole. Diastole just before contraction, systole. So, is the loading condition of the heart at the end of the relaxation and a filling phase, diastole, just before contraction, systole. So preload represents the degree of end-diastolic fiber stretch and diastolic volume, which is influenced by ventricular diastolic pressure and the composition of the myocardial wall. Typically, left ventricle and diastolic pressure, especially if higher than normal, is reasonable measure of preload. left ventricle dilation hypertrophy, and changes in myocardial distensibility, so-called compliance. This distensibility modify this preload. And afterload. If we've got preload, so we have to get afterload. Afterload is the force resisting myocardial fiber contraction at the start of a systole. Afterload is determined by left ventricle chamber pressure, radius, so radius and wall thickness at the time the aortic valve opens. Afterload. Clinically, systemic blood pressure at or shortly after the aortic valve opens correlates with peak systolic and stress and approximates afterload. So this is afterload. So Frank-Starling principle or Frank-Starling rule. So Frank-Starling describes the relationship between preload and cardiac performance. It states that normally systolic contractile performance represented by stroke volume or cardiac output is proportional to preload with the normal physiologic range. Contractility is difficult to measure clinically because it requires cardiac catheterization with pressure volume analysis, but it's reasonably reflected by the ejection fraction, which is the percentage of end-diastolic volume ejected with each contraction, stroke volume and diastolic volume. So ejection fraction can generally be adequately assessed non-invasively and echocardiography, nuclear imaging or MRI. So Frank-Starling principle is as preload increases, cardiac performance also increases. As preload increases, cardiac performance also increases. However, at a certain point, performance plateaus that then declines. In heart failure, what we talk about, due to systolic dysfunction, the overall curve shifts downward, reflecting reduced cardiac performance at a given preload. As a preload increases, cardiac performance increases less. With treatment, performance is improved. Okay? So actually, good diastole, good systole. Not good systole, good diastole. Good diastole, good systole. Good diastole, good systole. Good diastole, good systole. Okay. About the force-frequency relationship. Force-frequency relationship refers to the phenomenon in which repetitive stimulation of muscle within a certain frequency range results in increased force of contraction. Once again, force-frequency relationship refers to the phenomenon in which repetitive stimulation of muscle within a certain frequency range results in increased force of contraction. So normal cardiac muscle at typical heart rates exhibits a positive force-frequency relationship. So a faster rate causes stronger contraction and correspondingly greater substrate requirements, of course. But during certain point, during some types of heart failure, the force-frequency relationship may become negative, so that myocardial contractility decreases as heart rate increases above a certain rate. That is why we use, for example, stress test. So why we use this stress test? To provoke this phenomena. Augmentation of heart rate, force-frequency relationship becomes negative, and we see all picture of coronary artery disease clinically. So pain and failure and dyspnea is a sign of beginning of the heart failure. After stop stress test, the signs go. So this is a coronary artery disease. This is why the first question that we asked In medicine, and not only in cardiology, do you have, sir or lady, pain during physical exertion, during physical examination? Oh, physical stress. For example, you are going upstairs or going several blocks and you have pain or you have dyspnea. This is what? This is a force frequency relationship, but in negative way. Okay. So cardiac reserve. Cardiac reserve is the ability of the heart to increase its performance above resting levels in response to emotional or physical stress. Body oxygen consumption may increase from 250 to 1,500 milliliter minute during maximal exertion. So these mechanisms include increasing heart rate, increasing systolic and diastolic volumes, increasing stroke volumes, increasing tissue extraction of oxygen, the difference between oxygen content in arterial blood, in a mixed venous or pulmonary artery blood. In well-trained young adults, during maximal exercise, heart rate may increase from 55 to 70 beats per minute at rest to 180 beats per minute. Without big problems. And cardiac output may increase from 6 to 25 liters per minute. Do you realize this? Figure out these numbers from 6 to 25. At rest, arterial blood contains about 18 milliliter oxygen on deciliter of blood, and mixed venous or pulmonary artery blood contains about 14 milliliters and on deciliter. Oxygen extraction is this about 4 milliliter and deciliter. When demand is increased, oxygen extraction may increase to 20 to 14 milliliter deciliter. This mechanism also helps compensate for reduced blood flow in heart failure. About pathophysiology. So in heart failure, the heart may not provide tissues with adequate blood for metabolic needs, and cardiac-related elevation of pulmonary or systemic venous pressures may result in organ congestion. This condition can result from abnormalities of systolic or diastolic function, or commonly both. Although a primary abnormality can be a change in cardiomyocyte function, there are also changes in collagen and turnover of the extracellular matrix. Okay, sorry, collagen turnover of the extracellular matrix. Cardiac structural defects, for example, congenital defects, valvular disorders, rhythm abnormalities, including persistently high heart rate and high metabolic demands, for example, due to arteriotoxicosis, also can cause heart failure. Yeah, it may be. Heart failure with reduced ejection fraction, with low cardiac output, it's actually classic dysfunction, systolic dysfunction. So heart failure with reduced ejection fraction, also called systolic heart failure. Let's call it systolic heart failure. Global left ventricle systolic dysfunction predominates. It means, when we talk about systolic heart dysfunction, it means that global left ventricle dysfunction predominates on diastolic. The left ventricle contracts poorly and empties inadequately, leading to increased diastolic volume and pressure. Decreased ejection fraction. When we talk about decreased ejection fraction, it means less than 40%. It doesn't mean that 45 is okay. But when 40% is less than 40, this is a systolic dysfunction. Many defects in energy utilization, energy supply, electrophysiologic functions, and contractile element interaction occur with abnormalities in intracellular calcium modulation and CAMP production. Predominant systolic dysfunction is common in heart failure due to myocardial infarction, myocarditis, and dilated cardiomyopathy. Systolic dysfunction may affect primarily the left ventricle or the right ventricle. Left ventricle often leads to right ventricle failure. In heart failure with preserved ejection fraction, preserved, also called diastolic heart failure, left ventricle filling is impaired, resulting in increased left ventricle end diastolic pressure and rest or during exertion, usually normal left ventricle and diastolic volume, and globular contractility and hence ejection fraction remains normal, so more than 50%. So we talk about diastolic heart failure. However, in some patients, marked restriction to left ventricle filling can cause inappropriate low left ventricle end diastolic volume and thus cause low cardiac output and systemic symptoms. Elevated left atrial pressures can cause pulmonary hypertension and pulmonary congestion. Diastolic dysfunction usually results from impaired ventricular relaxation and active process, increased ventricular stiffness, valvular disease, or constrictive pericarditis. Acute myocardial ischemia is also cause a diastolic dysfunction. Resistance of filling increases with age, reflecting both cardiomyocyte dysfunction and cardiomyocyte loss, and increased interstitial collagen deposition. Thus, diastolic dysfunction is particularly common among older adults. Diastolic dysfunction predominates in hypertrophic cardiomyopathy. Other disorders with ventricular hypertrophy, of course hypertension. Hypertension is the first cause, not hypertrophic cardiomyopathy. Significant aortic stenosis and amyloid infiltration of the myocardium. Left ventricle filling and function may also be impaired if marked increase in the right ventricle pressures shift the interventricular septum to the left. Diastolic dysfunction has increasingly been recognized as a cause of heart failure. Estimates vary, but about half of patients with heart failure have preserved ejection fraction. And the prevalence increases with age, of course, in patients with diabetes. It's a very interesting part, But we remember metabolic syndrome with arterial hypertension and diabetes mellitus, so like twice, brother and sister, diabetes and hypertension. It's now known that heart failure with preserved ejection fraction, called diastolic dysfunction, is a complex, heterogeneous, multi-organ, systemic syndrome, often with multiple concomitant pathophysiologies. Current data suggest that multiple comorbidity, obesity, hypertension, diabetes, chronic kidney disease lead to systemic inflammation, widespread endothelial dysfunction, cardiac microvascular dysfunction, and ultimately molecular changes in the heart that cause increased myocardial fibrosis and ventricular stiffening. Question of compliance. So once again, obesity, hypertension, diabetes, and chronic kidney disease. It's what? Metabolic syndrome. Thus, although heart failure with reserved ejection fraction is typically associated with primary myocardial injury, preserved heart failure with diastolic dysfunction may be associated with secondary myocardial injury due to abnormalities in the periphery. And let's don't forget about heart failure with so-called mid-range ejection fractions. So quite recently, international societies have put forth the concept of heart failure with mid-range ejection fraction, in which patients have an left ventricular ejection fractions of 41 to 49. So this gap of ejection fraction from 40 to 50, actually very common. So actually you have to see that it's unclear whether this group is a distinct population of or consists of a mixture of patients with either preserved and non-preserved heart failure between systolic and diastolic blood pressure. But it might be degenerate to classic systolic dysfunction, systolic heart failure, so not preserved ejection fraction, reduced ejection fraction, or ameliorates due to your treatment, changing of lifestyle, etc., to heart failure with preserved ejection fraction. So this is a border. This is a border from 40 to 50. About left ventricle failure. In heart failure that involves left ventricle dysfunction, cardiac output decreases and pulmonary venous pressure increases. When pulmonary capillary pressure exceeds the oncotic pressure of plasma proteins about 24 mm Hg, fluid extravasates from the capillaries into the interstitial space and alveoli, reducing pulmonary compliance and increasing the work of breathing. Lymphatic drainage increases but cannot compensate for the increase in pulmonary fluid. Marked fluid accumulation in alveoli, pulmonary edema. Significantly alters ventilation-perfusion relationships. Ventilation-perfusion, VQ, relationship. Deoxygenated pulmonary arterial blood passes through poorly ventilated alveoli, decreasing systemic arterial oxygenation and causing dyspnea. However, dyspnea may occur before ventricular perfusion relationships, ventricular perfusion abnormalities, probably because the elevated pulmonary venous pressure and decreased work of breathing, the precise mechanism is unclear. So in severe or chronic left ventricle failure, pleural effusions characteristically develop. Further aggravation dyspnea. Minute ventilation increase, thus arterial oxygenation decreases and blood pH increases. So respiratory alkalosis. Marked interstitial edema of the small airways may interfere with ventilation, elevating this arterial oxygenation, a sign of impending respiratory failure. And right ventricle failure. In heart failure that involves right ventricle dysfunction, systemic venous pressure increases, causing fluid extravasation and consequent edema, primarily in dependent tissues, feet and ankles of ambulatory patients, and abdominal viscera. The liver is most severely affected, but the stomach and intestine also become congested. Fluid accumulation in the peritoneal cavity, ascites can occur. A right ventricle commonly causes moderate hepatic dysfunction with usually modest increases in conjugated and unconjugated bilirubin, prothrombin time, and hepatic enzymes, particularly alkaline phosphatase and gamma-glutamyl transperidase. The impaired liver breaks down less aldosterone, further contributing to fluid accumulation. Chronic venous congestion in the viscera can cause anorexia, malabsorption of nutrients and drugs, protein-losing enteropathy characterized by diarrhea and marked hypoalbuminemia, chronic gastrointestinal blood loss, and rarely ischemic bowel infarction. And cardiac response. In heart failure with reduced ejection fraction, so systolic dysfunction, left ventricular systolic function is grossly impaired. A higher preload required to maintain cardiac output. As a result, the ventricles are remodeled over time. During remodeling, the left ventricle becomes less void and more spherical, dilates and hypertrophies. The right ventricle dilates and may hypertrophy. Initially compensatory, remodeling ultimately is associated with adverse outcomes because the changes eventually increase diastolic stiffness and wall tension. That is, diastolic dysfunction develops, compromising cardiac performance, especially during physical stress. Increased wall stress raises oxygen demand and accelerates apoptosis, programmed cell death of myocardial cells. Dilation of the ventricles can also cause mitral and tricuspid valve regurgitation due to annular dilation when with further increase and diastolic volumes. So hemodynamic responses. With reduced cardiac output, oxygen delivery to the tissues is maintained by increasing oxygen extraction from the blood and sometimes shifting the oxyhemoglobin dissociation curve to the right to favor oxygen release. Reduced cardiac output with lower systemic blood pressure activates arterial baroreflexes, increasing sympathetic tone and decreasing parasympathetic tone. As a result, heart rate and myocardial contractility increase. Arterioles in the selected vascular beds constrict. Venoconstruction occurs and sodium and water are retained. These changes compensate for reduced ventricular performance and help maintain hemodynamic homeostasis in the early stages of heart failure. However, these compensatory changes increase cardiac work preload and afterload, reduce coronary and renal perfusion, cause fluid accumulation resulting in congestion, increase potassium exertion, and may cause cardiomyocyte necrosis and arrhythmias. And the renal responses. As cardiac function deteriorates, renal blood flow decreases due to low cardiac output. In addition, renal venous pressure increase, leading to renal venous congestion. These changes both result in decrease in glomerular fibration rate, GFR, glomerular fibration rate, and blood flow within the kidneys is redistributed. The filtration fraction and the filtered sodium decrease, but tubular resorption increases, leading to sodium and water retention. Blood flow is further redistributed away from the kidneys during exercise, but renal blood flow improves during rest. Decreased perfusion of the kidneys and possibly decreased arterial systolic stretch secondary to declining ventricle function activates the renin, angiotensin, aldosterone system, increasing sodium and water retention and renal and peripheral vascular tone. These effects are amplified by the intense sympathetic activation accompanying heart failure. The renin-angiotensin aldosterone vasopressin, antidiuretic hormone, ADH, system causes a cascade of potentially deleterious long-term effects. Angiotensin II worsens heart failure by causing vasoconstriction, including efferent renal vasoconstriction, and by increasing aldosterone production, which enhances sodium reabsorption in the distal nephron and also causes myocardial and vascular collagen deposition and fibrosis. Angiotensin II increases norepinephrine release, stimulates release of vasopressin, and triggers apoptosis. Angiotensin II may be involved in vascular and myocardial hypertrophy, thus contributing to the remodeling of the heart and peripheral vasculature, potentially worsening heart failure. Aldosterone can be synthesized in the heart and vascular independently of angiotensin II, perhaps mediated by corticotropin, perhaps nitric oxide, free radicals, and other stimuli, and may have deleterious effects in these organs. Heart failure that causes progressive renal dysfunction, including renal dysfunction caused by drugs used to treat heart failure, contributes to worsening heart failure and has been terminated the cardiorenal syndrome. Neurohumoral responses. In condition of stress, neurohumoral responses help increase heart function and maintain blood pressure and organ perfusion, but chronic activation of these responses is detrimental to the normal balance between myocardial stimulating and vasoconstricting hormones and between myocardial relaxin and vasodilator hormones. The heart contains many neurohumoral receptors: alpha 1, beta 1, beta 2, even beta 3, angiotensin 2 type and 2 type. First type and angiotensin 2 type 1 and angiotensin 2 type 2, muscarinic, endothelin, serotonin, adenosine, cytokine, natriuretic peptides. The roles of all these receptors are not yet fully defined. In patients with heart failure, beta-1 receptor, which contains 70% of cardiac beta receptors, are downregulated, probably in response to intense sympathetic activation. I call it sympathetic catecholamine, my name, intoxication. Catecholamine intoxication. I love this term. The result of downregulation is impaired myocardial contractility and increased heart rate. Plasma norepinephrine levels are increased, largely reflecting sympathetic nerve stimulation, as plasma epinephrine levels are not decreased. Detrimental effects include vasoconstriction with increased preload and afterload, direct myocardial damage including apoptosis, reduced renal blood flow, and activation to other neurohumoral systems, including the renin-angiotensin-aldosterone vasopressin system. Vasopressin is released in response to a fall in blood pressure via various neurohumoral stimuli. Increased vasopressin decreases renal exertion of free water, possibly contributing to hyponatremia in heart failure. Vasopressin levels in patients with heart failure and normal blood pressures vary. Atrial natriuretic peptide is released in response to increased active volume and pressure. Brain natriuretic peptide, BNP, is released from the ventricle in response to ventricle stretching. These peptides enhance renal exertion of sodium, but in patients with heart failure, the effect is blunted by decreased renal perfusion pressure, receptor downregulation, and perhaps enhanced enzymatic degradation. In addition, elevated levels of natriuretic peptides exert a counter-regulator effect on the renin-angiotensin-aldosterone system and a catecholamine stimulation. Because endothelial dysfunction occurs in heart failure, fewer endogenous vasodilators, for example nitric oxide, prostaglandins, are produced, and more endogenous vasoconstriction, for example endothelin, are produced, thus increasing afterload. The failing heart rate, other organs produce tumor necrosis factor, TNF-alpha. The cytokine increases catabolism and possibly response for cardiac cachexia, loss of lean tissue more than 10%, which may accompany severely symptomatic heart failure, and for other detrimental changes. The falling heart also undergoes metabolic changes with increased free fatty and acid utilization and decreased glucose utilization. These changes may become therapeutic targets. Aging. Changes with aging. Age-related changes in the heart and the cardiovascular system lower the threshold for expression of heart failure. Interstitial collagen within the myocardium increases, the myocardial stiffness, and myocardial relaxation is prolonged. These changes lead to a significant reduction in diastolic left ventricle function, even in healthy older people. Modest decline in systolic function and occurs within aging. An age-related decrease in myocardial and vascular responsivities in beta-adrenergic stimulation further impairs the ability of the cardiovascular system to respond to increased work demands. As a result of these changes, peak exercise capacity decreases significantly, about 8% decade after age 30, and cardiac output at peak exercise decreases more modestly. This decline can be slowed by regular exercise, regular physical exercise. Yes, it's very important. Thus, older patients are more prone than our younger ones to develop heart failure symptoms in response to the stress of systemic disorders of relatively modest cardiovascular insults. Stressors include infections, particularly pneumonia, hyperthyroidism, anemia, hypertension, myocardial ischemia. No, don't forget about this myocardial ischemia, for example, myocardial infarction, hypoxia, hyperthermia, renal failure, perioperative intravenous fluid loss, non-adherence to drug regimes or to low salt diets, and use of certain drugs, particularly non-steroid anti-inflammatory drugs. And I think it's largely enough for today. Huh? Yes, and don't forget, after this, we will, just in a few minutes we will see, in 1 minute maybe, you will see presentation of osmosis concerning heart failure, very good quality. Don't lose this possibility to see this osmosis presentation. Fantastic presentation, as all presentations of osmosis. Fantastic. And once again, thanks for your attention. Don't forget to make your donates, because without your donates we can't exist. Don't forget to make these donations. So how to make these donations? Yes, these donates you can find in description of this video in YouTube. In first description, just below, not in comment, but in description of this video in YouTube.